everyone. Thanks so much for being with me today. I am going to be discussing my research, and I would like to thank the AOTF for the opportunity to share my work with you today. So I was recently nominated for the Academy of Research, the goal of which is to advance the science of occupational therapy. And I see my role in this really as advancing the science of occupational therapy interventions for diabetes and really understanding diabetes through an occupational lens. And as I was thinking about my sort of whole career trajectory, and I kind of imagined and visualized it, I saw a tree with several branches. So bear with me with this analogy. The trunk of the tree is diabetes because all of my research has really centered around diabetes as a chronic condition and all of the ins and outs of living with and managing diabetes. And there have been other topics that have been foci of various strength, that some of which are incorporated in each of my research projects, but not all of them. So those are really the branches. So I thought I would take a minute to share my perspective on kind of my research as a whole through this tree and branches. So diabetes, why has it captured my attention so much? So like many researchers, I do have lived experience of loved ones with diabetes. I don't personally have it. So I don't have that lived felt experience, but I do have the experience as a caregiver and as a loved one of a person with diabetes. And it was in seeing this kind of up close and personal perspective on diabetes that I really understood how interwoven to everyday life it really is. So on the surface level, it may be seen as being fairly simplistic. So you eat certain foods, you follow, a structured diet, you maybe incorporate physical activity, you take medications. If you have type 1 diabetes, you take insulin, and that's kind of the extent of it. But the ups and downs of blood sugar on a daily basis and the complexity of incorporating all of these recommendations to manage your health well really are an occupation in their own right, which is why I was so excited to see health management included in the most recent OT practice framework as an occupation, because I really do see all of these components of managing a chronic condition such as diabetes as being an occupation. And in addition to being an occupation, it also intersects with all of our other valued occupations. So it intersects with our social life, with our work or school, our caregiving, our leisure activities. All the things we do are really influenced by the experience of living with a chronic condition. So this is really the core of my research focus. I think it's so multifaceted. I don't think I'll ever get tired of or feel like I fully understand everything about diabetes and chronic conditions more generally. So one of the important branches of my tree is a focus on adolescents and young adults. Much, but not all of my research has focused on this developmental phase, and it really captured my attention, in part because it's a phase of life where it's really challenging to manage a chronic condition. There are so many different competing priorities going on in a young person's life. They are taking on self-management tasks independently that their family may have supported them with. They're trying on different roles, different identities. There's just so much going on in this phase of life, and it really provides a good foundation for the rest of life. So if you can get support in this phase of life and really get started on the right foot, it's an advantage to you for the rest of your life in not only living with a chronic condition, but just life generally. So I really enjoy working with this age group, and it's been a focus of several of my studies. Another important branch of my research program has been a focus on health equity and health challenges that are faced by marginalized communities, especially low-income people and people of color, Latinx, Hispanic, Latino populations in particular. And as I was being immersed in literature on diabetes and adolescent and young adulthood, I was working with an endocrinologist who was in the county public health system, and he was one of my dissertation mentors. And the young people that I met through the context of working with him who were primarily Latinx. They were primarily publicly insured, lower income backgrounds. Their experiences were not represented in the literature I was reading about young adults and adolescents with diabetes. There was a very strong kind of bias toward white, more advantaged, privately insured populations. And I really just didn't see the experiences of the people that were being served in the county health system represented. So I wanted to work in that area to bring voice to their experiences and make sure that their needs were being met through interventions that were relevant to their lives and their challenges. The third branch of my tree is a focus on lived experience. And here was another gap that I saw in the literature on diabetes and chronic conditions. There was a lack of literature, I'd say, on how diabetes is managed in the context of daily life, in the context of everyday habits and routines, in the context of being at work, at school, at church, at the park, you know, in different environments, different social environments, doing different activities. There's a lot of focus, of course, on the medical aspects of diabetes. There's a lot of focus on the psychological aspects, even some on the environment, but not so much on the daily activities of people with diabetes. So that's something I was really interested in understanding better. And lastly, lifestyle redesign is a branch on my tree that really, to me, brought all of these components together. So as I was thinking about how occupational therapists might play a role in addressing the challenges faced by people with diabetes, I was also being immersed in research labs doing lifestyle redesign research, and I saw a natural fit there in how lifestyle redesign looks at a person's daily life and helps them develop the skills to self-analyze their occupations and alter their habits and routines in a way that makes or can make a chronic condition less burdensome, more well integrated with their other important life activities. So that's really kind of the start of my research career, was figuring out, is there a way we can develop a lifestyle redesign intervention for diabetes? So this is a timeline of my research. Whoops, I have a few animations that were not correctly put in there, I apologize. But the Real and Realty studies are really focused on this question of how can we develop an OT intervention that will address the needs of people with diabetes? And this has really spanned the whole rest of my career to date. So a second line of research after we did the Real and Realty studies, which were focused on young adults, we had an opportunity to implement a diabetes management lifestyle redesign intervention in a primary care clinic that was serving primarily older adults with type 2 diabetes. So we got to see not only the effectiveness of lifestyle redesign with a different population, but also study the process of implementation within a primary care clinical setting. A third research line that I have been engaged in is based on developing new care models for young adults with type 1 diabetes. And COYOTE stands for Care of Young Adults with Type 1, and it was started by my colleague and friend, Dr. Jennifer Raymond. And we've been working on changing models of care to better serve the needs of young adults with type 1 diabetes. And lastly, most recently, this project that I began in 2019, the FEEL-T1D, so Function and Emotion in Everyday Life, which is really revisiting my core interest in better understanding the lived experience of diabetes, this time using technology and EMA to better understand these experiences. So I'll give a brief overview of each of those 4 lines of research, and hope you'll come along on the journey. So the Real and Realty studies, these have focused on lifestyle redesign for young adults with both type 1 and type 2 diabetes. And you can see the kind of branches of the tree that most resonate are focus on adolescents, young adults, lifestyle redesign intervention, and health equity. So targeting intervention towards people with low SES or from minoritized communities. And in this work, I was really strongly influenced by the blueprint for translational research, which you see on the right of the screen. And this was in Florence Clark and Mary Lawler's chapter in Willard and Spackman, where they outlined kind of a method of developing a program of research. And I followed this from the beginnings of from really my dissertation up until today. So the beginning is really understanding a problem through a robust needs assessment, developing an intervention to address those needs, testing the efficacy, the effectiveness, the cost effectiveness, all of these components to go on and inform both theory development and new knowledge related to occupational therapy interventions. So, as I said, I started with needs assessment and really doing a lot of qualitative research with young adults with diabetes. Today, I might do it differently. I might have a more participatory approach to my research. But these are a couple of papers where we were looking at the daily activities and lives of people with type 1 diabetes and type 2 diabetes, forgive me. And then using that information to come up with an intervention to address those needs, and then testing the feasibility of that intervention. So that took up the first few years of my faculty position at USC when I was working on this KL2 award. So the next project I got involved in, we had funding through a KL1 award to do a small scale randomized study of the intervention that I had developed. So I called this the Resilient Empowered Active Living with Diabetes, or Real Diabetes study. And we actually also had a chance to look at some comparative effectiveness of different recruitment methods. We looked at different baseline data. And the big headline from this study was were the main outcomes. So we did find that occupational therapy improved both glycemic control, so that's blood sugar levels, which are predictive of longer term complications of diabetes, such as blindness, kidney failure, and also quality of life. So I was really excited to have this evidence of both a physical health benefit and a psychosocial or lived experience benefit from the intervention that I had created based on lifestyle redesign. So most recently, in 2019, we were funded to do a larger scale study of the real intervention. And this was fortunately designed to be delivered through telehealth. So we're in progress now with this study. We're recruiting, we have 160 some people as of today, with a goal of 210. And each of the people in the study get randomized to either usual care or 6 months of OT intervention. And I don't have any results to show from this study yet, or even any papers, because we're still in the process of recruiting our sample. But I did appreciate this quote from one of the participants. So this is someone who received OT through the Real T study. And I think it really captures what we're trying to do in our interventions. They said, the kindness, care, and attention to detail provided my OT has made the experience incredibly helpful. She was able to help me gain confidence as a person with diabetes, created a space where I felt comfortable to ask questions I may not normally ask my provider, and provided me with guidance to strengthen the skills necessary for managing diabetes. The experience was incredible, and I would recommend it for others. So these kind of stories from people who received OT really keep me going and keep me inspired to do this work. So I wanted to share one of those with you. And as I mentioned, after we published the study showing the evidence of the real intervention in improving blood glucose control, we had an opportunity to implement this through pilot funding from our institution and from the Department of Health Services in a primary care setting within the LA County Public Health System. And so the goal here was really to understand, as I said, the effectiveness of lifestyle redesign for this different population, because we previously tested it with young adults, most of whom had type 1, and to better understand how we could integrate into a primary care setting. And the focus here, really, you can see from the branches, was health equity. So this was a population that was primarily uninsured or publicly insured, lower income, and primarily minority. And so through this study, we did find evidence to support, again, both physical and health behavior improvement. So again, HbA1c, that's blood sugar levels, they dropped as a result of the intervention. The stars indicate statistical significance. Also saw an improvement in blood pressure, as well as this is the SF20, and this is a range of different health, mental and physical health outcomes. So improvements in pain, in role functioning, physical functioning, and so forth. So we were really encouraged by this. And we continue to collaborate with the health system and the primary care clinic and have hopes of doing a larger scale study in the future. So the third line of research I mentioned, this is spearheaded by my colleague, Dr. Jennifer Raymond, and she's the director of the Diabetes and Endocrinology Division at CHLA, the Children's Hospital Los Angeles. And the focus here was really to adapt models of care to better fit the needs of adolescents and young adults with type 1. And there were a few components to this. First, which was innovative at the time, was implementing home telehealth. So allowing adolescents and young adults to log on from home and meet with their provider. Another piece of this was virtual peer groups. So having a young adult peer mentor lead groups where young people with type 1 could meet one another and compare experiences and find support. And my involvement in this project really was getting involved in the provider side of things. So again, we have virtual group appointments and the home telemedicine. And what we did is we adapted this because Dr. Raymond brought it from her previous setting in Denver, Colorado. She brought it to a large urban hospital setting in Los Angeles. And so we adapted it. And in doing so, we found that the patients and our patient advisory board really valued their communication and relationships with providers. And we realized we needed to kind of have a systematic approach to promoting strong provider communication and collaboration. So together with my colleague, Dr. Jesus Diaz, we developed a provider communication training where we incorporated elements of shared decision-making and motivational interviewing and coached the providers in better patient-centered communication, which was a really rewarding process. And we're now actually in the process of a new grant, which is to develop a toolkit to disseminate these approaches to clinics nationwide, which is really exciting. So last, this recent project called Feel, Function, and Emotion in Everyday Life with type 1 diabetes. You can tell I love my acronyms. This is really a return to studying lived experience, which I really value, as I did toward the start of my career, and a focus on health equity. So in this study, we really focused on recruiting diverse populations so that our findings would be relevant to a wide range of people living with diabetes. So what's the goal of this study? So here we have a picture of 24 hours of blood sugar data from a person with type 1 diabetes. And these red and yellow lines are kind of the ranges that you want to stay within. It's thought for optimal health. Note that a person without diabetes would have a line that was straight across just above this red line. It would just be night and day, the difference. So we wanted to better understand the implications of having blood sugars that are going up and down throughout the day. And what we did have was qualitative data from people living with diabetes who would describe these feelings as being like a roller coaster ride, feeling really effortful, like climbing a mountain, high blood sugars making them feel irritable and exhausted, low blood sugar making someone feel hopeless, depressed, or anxious. Just all of this rich information from people. And so we were seeking to put a different perspective on it and study this using technology to really understand it like a larger, potentially more generalizable way of looking at this. So this study incorporates blood glucose measurement through those sensors. So this is worn on the arm and it measures blood glucose every 15 minutes for 2 weeks without the person having to do anything. It's just set it and forget it. They also wear an accelerometer for those 2 weeks, which tracks their sleep and their physical activity. And lastly, we asked participants to carry a cell phone, which 6 times a day, it asks them questions about their mood, about their function, and their cognition. So it has both self-report questions, and it has some cognitive tests to look at sustained attention and executive function. But also we're capturing, you know, what they're doing, who they're with, how they're feeling, so that we can combine all this data and really look at that experience of living with diabetes in a more fine-grained way. So this is just a sneak peek at some of our findings. I'll be presenting this at the American Diabetes Association conference later this year. But we looked at how blood sugars overnight while someone was sleeping affected their function the next day. So for that, we looked at physical activity, how much they were moving. We looked at their cognitive tasks, and we looked at their self-reported activity engagement, fatigue, and pain. So here is what we found, and we looked at it for 3 variables. So if they had low blood sugar overnight, below 70, if they had high blood sugar over 250, and if they had more or less variable blood sugar. So the CV is coefficient of variation. So we found people who had more low blood sugar overnight had poorer sustained attention the following day. People whose blood sugar had been high overnight had more fatigue and moved less. They had fewer steps over the course of the next day. And people whose blood sugar had been more variable overnight, more up and down, had poorer sustained attention, more fatigue, and participated in less demanding activities. So when they 6 times a day told us what they were doing, we coded those activities into high demand activities like working or caregiving, or lower demand activities like just chilling or watching TV, those kinds of things. So we found that people chose less demanding activities on the days following a night when their blood sugar had been more variable. So this is just one example of the kinds of things that we are trying to learn about the experience of living with diabetes and how some of these things impact day-to-day functioning. So I wanted to close just with thanking and acknowledging all of the many, or some of the many people. I couldn't fit all the people on one slide by a long shot, but some of the groups of people who have been most influential in my career, my research thus far, in particular my mentors, Florence Clark, my dissertation chair, and my first boss, Mary Lawler, Ann Peters, who's an endocrinologist who's been a wonderful mentor on the clinical side of things, Donna Sprite-Metz, who's a psychologist who's all about mobile health and has been really pivotal in the field study. My compadres, my friends and colleagues who are the people I really lean on to support me both personally and professionally. My mentees definitely merit a shout out, because without them, I've taken such great pleasure in mentoring students, and I really learned something from each and every one of them. They've been such an important part of my research program. We also have some great staff involved in our research, the LRCC crew, funders, of course. Without the money, none of this would be possible. And last but definitely not least, all of my family members for supporting the many long nights and travel away from home to do conferences, and patience with the Zoom meetings during COVID and all of those things. So, and also thank you, the audience, for coming today and listening to this. And I'd love to hear from you if you have any thoughts, questions. You can see some more about our research on our website, chan.usc.edu/LRCC. That's Lifestyle Redesign for Chronic Conditions, and there's my email. Thank you so much for your time.